So just know that we are already, I think, entering that phase. And probably by the time you're starting systemic leakage of cells or PPHs in the hand, then you know most likely platelets are below 40,000. Okay, if the patient convulses and they have ecchymosis in the eyes, just know most likely your platelets are below 20,000, because you start intracranial bleeding when you are less than 20,000, and that means you have conjunctival hemorrhage and most likely you end up with a convulsion. Calcium is very rare. When you lose blood, it's part of the coagulation cascade. When you lose blood, you're losing coagulation factors. So calcium is very good for cardiac contractility, vasomotor tone, and also activating the fibrin clot. So you need to replace it. And also the blood we put in has a chelator, sodium citrate, that takes away calcium. So continuously, you lose calcium, the chelating agent is in the blood you're giving, so you need to replace calcium for that matter. But also it is kind of protective long term, because sometimes you get old blood that has a risk for hyperkalemia. So you need to desensitize the heart, and the calcium comes in very handy. Sodium bicarbonate, very, very good to replace the acidosis that you're creating because of the shock, because what kills the patient is acidosis, coagulopathy, and hypothermia. The monitoring has been talked about. I can't talk much more about it, but you need to do the WHO monitoring, which is the heart rate, blood pressure, SpO2 temperature, and tidal carbon dioxide. When we are giving all these blood products, let's try to be cognizant of the fact that we need to keep the patient warm. Sometimes you can't warm the blood, but make sure that you have a bear hug around the patient. Or if you can actually use standard infusion pumps that have a warmer and set the temperature maybe 36 so that you can maintain the core temperature. Also, we look out for static parameters. You may not have all the monitors in a bad health center, but the static parameters is you look at your urine output, look at your capillary fill, look at your NIBP, and also you can look at your level of consciousness if the patient is getting back, for example, and also your respiratory rate. Lactate can only be done in high centers. Then, if you're in another part setting, and do the dynamic parameters. You look at central venous pressure, you have put a central line. You look at arterial blood line, arterial lines, and you can do an echo, have an echo around. So that has been done many times. And you look at cardiac contractility. If you look at your ventricles and they are literally touching missing ventricles, it means my body is not good enough and that you try to pump empty pipes. So you need to give more volume so that they happen. You can also do examples to the phobia and look at the bigger cover, look at how collapsible it is. And there is a side that actually you can give more. You can give more volume. If it is collapsing, you can give more volume. If it is not collapsing, it means you have a lot of volume, but the heart is weak, so it means you can increase your vasopressors. And the typical inotrope we use is dobutamine to increase our contractility without increasing so much of the heart rate. And then also you can do a leg raising. While on table, take your initial blood pressure and note it, and then raise the patient's leg and see. If they are able to increase pressure 10 millimeters above what you had before systolic, it means actually you still have empty pipes, so you can still give more volume. There's the role of damage control surgery. Damage control surgery is one of the things that can help you in the DIC situation. You've done everything, you know the patient still not clotting. As much as you can, remove the remaining clots, because those are going to be part of your problem. They'll consume all your coagulation factors. And then put in hemostatic mops. There are special mops made, which I used to see in Somalia, because I did a bit of work with the military in Somalia and Mali. And for them, they use actually hemostatic packs. They are gauze packs, but they have a powder in them that you keep on packing and then you close up, and they improve on your coagulation. But even in those in our setting, you can use heavy big mops and put pressure, especially in areas that you may think blood will collect up. Because if you can close up all the gutters, it means there will be no room for blood collecting up and increasing on your coagulation. I mean, yeah, dysfunction. And then also putting surgical control on areas that you think may be the reason why you're bleeding. There's also a room for preventing further contamination. So make sure, because it is rushy surgery, that you've cleaned up, lavaged very well, but also given a broad spectrum antibiotic, because you might do so much work and end up with sepsis straight away. Do not be in a rush to close up everything. So you put pressure and just close up and take the patient to ICU. Before you can close, before you do this in good centers, what else they've done is also called in a radiologist. The radiologist has a role in damage control surgery. So we call it damage control interventional radiology. And earlier on this year, when we ended the report trial was part of the interventional radiology. It was the first ever trial in Uganda, but elsewhere they've done them, especially the Western countries, Scandinavia. And their standard of care is if someone is a risk patient for untreated PPH, they put in an endovascular catheter, which occludes the aorta so that you can have less blood at the time of flowing down to the target organ. So we use this to prevent uterine blood flow, and it was intermittently done every 15 minutes for 1 hour to prevent. At least it can work. In our environment, we've tried to prove the efficacy of it, but elsewhere they've done it at the standard of care. And sometimes we just embolize. I've done also embolization at privately at IHK, where it's quite expensive, but life is more precious. Life is priceless, but it's one method you can do. One of the things that will kill your patient is cytokine storm. Every time you have an inflammatory and trauma to the body, your body goes in an inflammatory state, but also you're transfusing blood, which is a foreign body. So your body is going to fight.
Anesthesia drug, and naturally, Apple will have your guidance. I think all of us have heard of stories where old ladies are known for giving men who are drunk urine and then they recover. But they just using it we keep our patients. We are aware, we should be constantly aware of the clinical trial. That's like acidosis, hypothermia, and coagulopathy. We should keep them more. Before the patient goes to ICU, we need to make sure that our patient's tube is still in place. The patient is still getting ventilated because sometimes the patient is under muscle relaxation. We need to inform the ICU team that we are coming. We shouldn't just rush. Or if you are referring the patient, tell the referral site we are sending home. Average, we might take an hour so that everyone prepares. And then, if someone needs blood, continue giving blood, but if they are in a resuscitative state, you give as much. If they are in a revival state, you start slowing down. You monitor for complications. One of them is a kidney injury, and the two most serious is injury. Because they spend so much blood, they start fighting back. Sometimes they are against. You remove perfusion, and then they get a pneumonia question. But sometimes also we've given so much blood in a short time, and they get TAPO, transfusion-associated circulatory overload. They behave as if they have cardiac failure suddenly or heart failure. We should repeat all our labs because we have fluid overload, electron exchange, potassium, sodium, calcium, magnesium. And then we should sit as a team to debrief ourselves. What did we do good? What did we do bad? Do we need to come up with protocols like we are doing now? Do we need to have action plans or improve on maternal? And also circulate this knowledge of our success. The take-home message is very clear. You can't work as a lone wolf, you need a team. Always make sure that you are secure all the time and transport with the patient with the airway is secure. Use monitoring, both invasive and non-invasive. Start your protocol with the ratio of 1 to 1 to 1 for better outcome and duration of DIC. Remember, do the labs. Check on fibrinogen if you can. Have a conference with the family. Talk as a team of the good, the bad, and the ugly about the procedure you've done.